Hello students, welcome to this very important session on operative vaginal deliveries. So, when we talk about operative vaginal deliveries, we talk about both the forceps delivery as well as the vacuum delivery. In this session, we will be talking only about forceps delivery. We have another session for vacuum delivery. So, forceps was an instrument designed by the Chamberlain family in the 16th century, and then it was kept a family secret for almost over 100 years. And only in the 17th century, the obstetric forceps was popularized by Simpson. This is a specialized instrument which assists in the delivery of the fetus. So, let us talk about the instrument per se. This instrument has two branches. Each branch has a blade, then a straight portion, that is the shanks. There is a lock followed by the handle. The branches are also called blades commonly. So, there are these two blades, the right and the left blade. The right and left nomenclature depends on which side of the maternal pelvis will that blade enter. So, if this blade is entering, it will enter into the maternal right side. So, this is the right blade, whereas this blade would be entering the maternal left side. So, this would be the left blade. We have seen the different parts of the blade. Besides that, there are two important curves of this blade. This is the portion of the blade which is going to hold the fetal head. So, this is known as the cephalic curve. When we look at the blade from the side, we can see there is a curvature. This is there to negotiate the curvature of the pelvis. Hence, this is known as the pelvic curve. There are different kinds of locks on the blade. What you see here is a double slot lock. This is also known as the English lock. There are other types of locks, the French lock, which has a screw and a bolt, and a sliding lock which is found on a specialized forceps called the Keelan's forceps. So, there are many types of forceps available, but the common ones which are used are, as you can see here, the first one, this is the smaller and a lighter form of the forceps. This is known as the Wrigley's forceps or the outlet forceps. This is the commonest one used. The second one here is the Simpson's forceps, also known as the mid cavity forceps. And the third one here is the specialized forceps called Keelan's forceps. This is used for rotation of the fetal head or correcting asynclitism. The last one, what you can see, is the Piper's forceps. This is also a specialized forceps used for delivering the aftercoming head of the breech. We have a very specialized instrument called the Das forceps. This was created by Dr. Das of Calcutta, India. What he realized was that the pelvis of Indian women was smaller compared to their European counterparts, and the babies were also smaller. So, he modified the mid cavity forceps, and this came to be known as the Das forceps. So, the maternal indications are when the mother is exhausted or there is inadequate expulsive force, then we can apply the forceps. If there is prolonged second stage due to some other reason, it may happen due to epidural analgesia during labor. So, in such cases, we can cut short the second stage by applying forceps. If the mother has cardiac disease or she has eclampsia or she is a case of post-cesarean delivery, in such cases we want to cut short the second stage of labor and we can apply forceps or vacuum. The fetal indications include the commonest one being the fetal distress in second stage of labor. If there is cord prolapse or there is abrupture placenta, that means premature separation of placenta in the second stage, then we have to hasten up the delivery and we apply forceps. In the aftercoming head of the breech as well as in low birth babies, we can apply forceps for delivery. Now coming to the functions of the forceps, the first one obviously is traction. We apply the forceps and we give traction to the fetal head for it to deliver. I have told you there are specialized forceps like the Keelan's forceps which are used for rotation. If the internal rotation is not complete, we can use forceps to complete the internal rotation and thereafter deliver this fetus. In a preterm fetus, we do not want the fetal head to be compressed by the genital tract soft tissues. So, we can apply the forceps. This acts as a protective cage around the fetal head. Some obstetricians use one single blade of the forceps to assist in extraction of the fetal head, and this function is called the vectis. Before we apply forceps, there are certain prerequisites which must be met. There is a mnemonic for the forceps. First one, F being fully dilated cervix. So, the cervix should be 10 centimeter more dilated. That would be fully dilated cervix. Only then we should apply the forceps. Head should be 1/5 or nil palpable abdominally. What does this mean? The head should be engaged. So, when the head is engaged, when we do abdominal examination, 2/5 or 1/5 may be palpable. So, that is another prerequisite. Membranes must be ruptured, otherwise my forceps is going to slip. Uterine contractions should be present. We need the bladder to be empty so that there is no injury caused to the bladder during fetal extraction. The presentation and position should be favorable. For example, if it is a mento-posterior position, there is no further mechanism of labor, hence applying forceps is not indicated. There should be satisfactory analgesia, and in the pelvis there should be no cephalopelvic disproportion. So, once these prerequisites are met, then we can go ahead and do the vaginal delivery using forceps. Forceps application is a surgical procedure. So, it is important that we take due consent, informed consent from the mother, where she has explained the procedure and the risks and the benefits of forceps delivery. The operator needs to be skilled in forceps application, otherwise it can cause more harm than good. There has to be a backup plan. That means there should be facility available for emergency cesarean section, because in case forceps application fails, the next option is to take her up for cesarean delivery. Presence of neonatologist is important for every delivery, especially so with forceps application. The forceps application has been classified depending on the station of the fetal head when we apply the forceps blade. The commonest one is the outlet application, which is when the fetal scalp is visible without separating the labia. At this time, the fetal head will be at the perineum, and that would be +3 station or more. The sagittal suture is usually in the midline because the rotation is complete. Sometimes the sagittal suture may be in 45 degrees either side of the midline. So, this is known as the safe angle, and we can apply the forceps. Next type of application is the low cavity application, where the fetal head is at +2 station, and again the rotation of the fetal head is either complete or within the safe angle. Next is the mid pelvic application. Here the station is above +2, but below 0 station. That means the head is engaged. The last one is the high application, which is not done anymore. So, if the head is not engaged, we do not apply vacuum or forceps. Depending on the type of application, it can be a cephalic application or a pelvic application. In cephalic application, we disregard the maternal pelvis and we apply the forceps blade entirely based on the position of the fetal head. So, this is cephalic application, and pelvic application is when we apply the blades of the forceps depending on the maternal pelvis with disregard to the position of the fetal head. So, this would be pelvic application. This is not done usually because it can damage the fetal head. But if the internal rotation is complete, then the pelvic application and the cephalic application are the same. Always the left blade is applied first. So, left blade is held in the left hand of the operator in a pen holding grip. Thereafter, the middle and the index finger of the right hand are placed between the fetal scalp and the posterior vaginal wall, and the forceps blade is slid into the sacral hollow. Once it enters the sacral hollow, we turn it to lie on the left side of the maternal pelvis. So, this is known as the wandering application. After that, now we have to apply the right blade. So, now the right blade is held in the right hand of the operator in a pen holding grip. The middle and index finger of the left hand are between the fetal scalp and the posterior vaginal wall, and the right blade is applied directly to the right side of the pelvis. So, this is known as direct application. Once both the blades are applied, now we have to check whether the application is correctly done. To check whether the forceps blade have been correctly applied, we will notice that both the blades they lock easily. The sagittal suture will lie in the midline of the shanks, and the lambdoid suture will be equidistant from both the blades. So, this is how we check whether it is a correct application, that is bimalar biparietal placement of the forceps blade. If we have applied the forceps blade and the head is still high, so first we have to bring down the fetal head. So, the direction of traction is downwards, and once the nape of the neck is visible, thereafter that means the head has already reached the perineum. Now, we change the direction of the forceps and give the traction upwards to deliver the fetal head by extension. This diagram shows you the special application of forceps in case of an aftercoming head of the breech. Once the body of the baby is delivered, the assistant will hold this baby in a OT towel, and the operator has to apply the blades from below the body of the baby. And thereafter, once the forceps blade are applied, both the body and the forceps they are moved upwards in an arc to deliver this aftercoming head of the breech. In some cases, we have to cut short the second stage of labor, and forceps is a useful instrument in such patients. If the patient has eclampsia or a heart disease or a previous cesarean delivery, if the baby is low birth weight or there is delay in second stage of labor due to epidural analgesia, in all such cases we apply forceps, and this is called prophylactic forceps application. One of the prerequisites of forceps delivery was there should be no cephalopelvic disproportion, but sometimes the obstetricians after clinical examination feel there is a borderline cephalopelvic disproportion which can be overcome by application of forceps. So, this would be called trial of forceps, and this is to be done inside the operation theatre, keeping everything ready for a cesarean delivery. So, in the operation theatre, the forceps application will be attempted or tried. If it is successful, well and good. If it is not, then we go ahead with cesarean delivery. Once we have applied the forceps and we apply traction, within each pull there should be some amount of descent of the fetal head, and within 3 to 4 attempts the head should be delivered. But if that does not happen, then we must abandon this procedure, and this procedure is said to be failed. So, this unsuccessful application of forceps is failed forceps, and the other option after this is to take the patient up for cesarean delivery. This may happen because the clinical assessment of pelvis may be incorrect, or the cervix may not be fully dilated, or there may be malposition of the fetal head which was undetected earlier. So, all this can contribute to failed forceps. Coming to some of the advantages of forceps application over the vacuum instrument. Forceps is quicker to apply and to deliver the fetus compared to vacuum, because in vacuum once we apply the cup, we have to wait for the vacuum to develop, only then we can apply traction. Forceps can be applied in a preterm neonate, whereas vacuum is contraindicated in such cases. In phase presentation or after coming up head of the breech, we can apply forceps, whereas vacuum is contraindicated. The scalp injuries or bruises are less by forceps application compared to the vacuum, and forceps application has a better success rate compared to the vacuum application. Since forceps is a surgical procedure, it has its own complications. Complications are also divided into maternal complications and fetal complications. The maternal complications include lacerations, or if there is episiotomy given, there may be extension of episiotomy leading to hemorrhage. Many times it can precipitate postpartum hemorrhage due to uterine atony. It may result in injury to the bladder or the rectum. All these lacerations can get infected, and there may even be fracture of the coccyx if the forceps is not correctly applied. So, these are the dreaded complications of forceps application for the mother. For the fetus, it can cause bruising on the face or on the scalp. There may be cephal hematoma. It can result in fracture of the skull, especially if we are trying to forcefully lock the blades of the forceps. It may result in facial palsy or brachial palsy. There may be intracranial hemorrhage and late neurological sequelae of forceps application, especially if it is incorrectly applied or the operator is not adequately skilled in this forceps application procedure. So, now we will show you a small video demonstration of forceps application.
As we have already discussed the prerequisites, as you can see here, the cervix is fully dilated, the head station is +2 or more, and the rotation is almost complete. The patient has already given her consent, her bladder has been emptied, and now is the time to apply the forceps. So, let us see what are the forceps blades. There are 2 forceps blades. Coming to the different parts of the forceps, this is the handle, followed by a lock. This is a double slot lock. The straight portion, which is known as a shank, and then the blade of the forceps. This forceps blade has 2 curves. This curvature, as you can see, which is going to be in contact with the fetal head, is the cephalic curve. If you look at the blade from a side, as you can see, this particular curvature, this is going to negotiate the curvature of the pelvis, hence it is called the pelvic curve. So, before we apply the forceps blade, we must do a phantom application where we assemble the forceps blade so that we know that both the branches are the same. Now, first we will apply the left blade. So, the left blade is held in the left hand in a pen holding grip. The middle and the index finger of the right hand will protect the vaginal wall, and then this left blade will be slid into the sacral hollow. Once it goes into the sacral hollow, we will turn the blade to the left side. So, the right blade is held in the right hand in a pen holding grip. The middle and index finger of the left hand will protect the vaginal wall, and the right blade will be slid to the right side, and then we will lock the forceps. So, if the forceps blade have been correctly applied, the lock will happen easily. The sagittal suture will be in the middle of the forceps, and the lambdoid suture will be equidistant from both the blades. Thereafter, for applying traction, so since this is an outlet application, we will hold the forceps blade with the right hand and then apply the force from the elbow. Thereafter, we will give traction and lift the fetal head out. Once the fetal head is delivered, then we can disassemble the blades and remove the blades. So this is the forceps application.